So in this webinar, we're going to be drawing, as Dina said, on the best practice guide. We're talking about brain health and cognitive impairment and dementia, a lot of it in a generic way, but the particular focus tonight is about Aboriginal and Torres Strait Islander people and communities, and what you particularly need to know and think about in order to provide really good healthcare for these patients. So much of the content of the webinar draws on the guide. We'll be presenting a way of thinking about brain health from conception onwards, and how good primary healthcare throughout life can support brain health and reduce the risk of cognitive impairment and therefore of dementia. And we'll discuss some of the practical MBS and PBS aspects of care. This is a sort of map of how their best practice guide is organised, and the approach that we've really built the Letschat Dementia project around. So the area that's about promoting brain health and reducing risk, so that's really really key, not a major focus of tonight's presentation. That will be one of the later webinars in the series. And then an area that's around detection, which is one of the primary aims of the project, and the different areas of living with dementia, which we'll be talking about this evening. So this webinar is the first of 6 webinars, and the focus is really around aspects of care that are particular for Aboriginal and Torres Strait Islander patients and communities. Excuse me. So some of the key considerations are the cultural context of providing healthcare for Aboriginal and Torres Strait Islander peoples, the importance of, and particularly around dementia care, the importance of respect for elders and their roles in communities, the connection to place, to country and home, that's so key to identity for Aboriginal and Torres Strait Islander people, the importance of family and relationships and what that means for care, the family and cultural responsibilities, in decision making in many aspects of care. The holistic way of being, the whole person, whole of life understanding of social, emotional, spiritual, physical health and well-being. So that cultural context is really key. I've included the map to just really as a depiction around this next point, to really understand, and so many non-Indigenous people don't deeply know and understand the cultural and linguistic diversity of Aboriginal and Torres Strait Islander peoples. And this map is, obviously the details impossible to read, but the lines are a depiction of different Aboriginal and Torres Strait Islander countries and reflect different language groups. And, often I think a way of understanding that, the Colombian Canadian anthropologist Wade Davis, who described a language represents a unique response to the fundamental question of what it is to be human. So to think of, a language group is a distinct identity, and this landmass has for tens of thousands of years been fully inhabited. So all those, a lot of the script on this are language groups. This is fully inhabited, not densely populated, but fully inhabited. That there's a diversity of communities in, across the geography of this landmass, and a diversity of health settings in which people access healthcare. Really key to understand the impact of colonisation and subsequent harms, and the intergenerational impact of that, and trauma-informed, to know and practice the principles of trauma-informed care. So these are all reasons for thinking about Aboriginal and Torres Strait Islander people in particular, and reasons to have a best practice guide for Aboriginal and Torres Strait Islanders. Okay, a few other sort of background points. The population, Aboriginal and Torres Strait Islander population, is ageing. There are more people living longer. Dementia rates are high. So there's high prevalence of dementia and higher onset at a younger age. And also important to really acknowledge that most people don't develop dementia and live well to older age. So a little more about the prevalence. This means like 1 in 5 people over the age of 50 years has some form of cognitive impairment in Aboriginal and Torres Strait Islander populations. Alzheimer's disease and vascular cognitive impairment are the commonest forms of cognitive impairment and dementia, but the numbers are really too small to determine, the true differences. There's a lot of combined combination of Alzheimer's and vascular dementia. And one of the myths that's around is, in fact, that there are very low rates of dementia that are secondary to alcohol. So just to look at the graph there, the yellow is the Australian population overall, and clearly there are just much higher rates. The blue, New South Wales, so city and regional, Torres Strait Islanders are grey, and the Kimberley remote regions in orange. So, overall, there's 3 to 5 times the rate of cognitive impairment and dementia compared to the non-Indigenous population. Okay, a little bit about the risk factors for dementia. This is an image that the Lancet Commission systematic review developed that really outlines the modifiable risk factors. Their first systematic review, I think, was published 2017 and then updated last year, and they recognised 12 modifiable risk factors. And I think, the really key parts about this is that it highlights the life course, the sort of early life, midlife and later life risk factors. And just to, be clear, that's for those relative risk figures that are given there. That is, it's the probability of an outcome in this group compared to the general population. So, 1.6 means a 60% increased risk. The percentage of each of these risk factors within Aboriginal and Torres Strait Islander communities obviously varies and isn't known, but we do know that studies addressing dementia in Kimberley and in New South Wales and in North Queensland show that head injury and cerebrovascular disease, childhood trauma, poor vision and impaired hearing and polypharmacy are some of the really key contributing factors. So overseas studies have also demonstrated that the incidence of dementia has decreased in many high and middle income countries in the last 3 decades, so that public health measures are likely to delay or prevent dementia. And these are some of the figures from the Letschat Dementia project, which as yet are unpublished. So, really key, 64% of people had 4 or more risk factors. And these are based on chart audits of people aged over 50 in 12 ACHAs that are part of the Let's Chat Dementia project. So really striking the head injury, the much higher rate risk from head injury, and the higher relative risk from childhood trauma. Okay. So really key message that brain health is a product over the life course, and that living well supports ageing well. So primary healthcare has a huge role from conception, throughout life. And this is, antenatal care, and then in supporting children to thrive, developmental tracking and engagement in learning, ear health and hearing. People probably know there, very high prevalence of otitis media and hearing impairment, and which has the potential to have huge impact on neurodevelopment. There's also all the work influencing health behaviours like smoking, healthy weight, diet, physical activity, and so on. There's the secondary prevention work, hitting clinical targets in blood pressure control, lipids, diabetes, and so on. Also recognising trauma and the impact of trauma, and supporting social and emotional wellbeing and mental health. So I think this is a really key part of the project, is to place dementia, brain health, and cognitive impairment and dementia care in the context of lifelong wellbeing, and really thinking very specifically about how primary care supports that throughout the life course.
I'm just going to talk a little bit about dementia identification and very briefly about management. And just thinking about Auntie Molly, she's 68 years old, and she lives with her son, Frank. And she has metabolic syndrome, for the GPs who are watching, diabetes, hypertension, and obesity. And this is very common in the Aboriginal population and the non-Indigenous or non-Aboriginal, non-Torres Strait Islander population as well. And she was taken from her family as a young child. So she's what we call the stolen generation. The stolen generation carry a lot of trauma with them. And as Mary pointed out, childhood trauma is one of the risk factors for dementia. So now Auntie Molly comes to see you with Frank. She doesn't always come with Frank, but on this occasion she comes with Frank, and he's telling you that he's worried about her memory, that she's more forgetful than she used to be, and she's moody and withdrawn, and she doesn't want to go to the elders group anymore. And what are you going to do about it? And he's worried because she forgets to take her diabetes tablets, and she is sitting there and she is not impressed. She doesn't think there are any memory problems, and she's a bit upset with Frank for bringing up this issue. Okay, so is this perhaps dementia? This is the question. So what is the clinical recommendation? So the clinical recommendation in the Letschat guidelines is for case finding from the age of 50. And Auntie Molly's in her 60s, so she's well above the age of 50. And what does case finding mean? Well, that means you don't just ask everybody to do a cognitive function test. You pick people who are at risk. And who's at risk? Well, people whose families are complaining that they have bad memory are at risk. So we've got that there as passive. A client or family member or friend raises concerns about thinking or memory or confusion, And sometimes it might be behaviour, actually. And we noticed that Auntie Molly wasn't going to the elders group anymore and was withdrawn. So sometimes it's behavioural even more than memory. Or it could be that you notice yourself. And I know in my practice, I notice if my patients are forgetting to get their scripts, because it shows up in red on my practice software. And I say, have you had your script? And they say, oh, I'm sure I have, but they definitely haven't, or they haven't been taking it. There's also an active form of detection of dementia or cognitive impairment, and that is to just identify all the people with risk factors. And we ran through those risk factors. Mary ran through those earlier. So, for example, in our practice, we've put together all the people with diabetes, and we've decided that it's probably worth checking out their memory because that's such a big risk factor, plus their age. Or we might just ask them a few questions about how's your memory. This is possible in one of the health assessments that we can do in general practice. And we might ask about memory or about thinking. And we'll just move on, Mary, because there's a few example questions. Yes, here we are. So you can just ask, do you have any worries about your memory or thinking? And that's not too confronting, because people can just tell you no. That's fine. You can take that at face value, but you might know. In Auntie Molly's case, she would say, no, I don't have any worries, but you know that her son Frank does. So you take the whole context into account. As Mary said, that's very, very important when working with Aboriginal and Torres Strait Islander people. So, or you can ask if anyone in the family has had any problems with memory or thinking. Is it possible to go back to that previous slide? Yeah. Thanks. I just wanted to mention the annual health check there because this is a new recommendation in the annual health check to ask those two questions. And then if the person says yes, or if the family, as in Frank in this case, says yes, or if in fact the staff raise concerns. So the other day, my practice nurse said to me, you know, Judy, who's actually is an Aboriginal and Torres Strait Islander patient of mine, you know, she's come to me several times asking if I've done that driving assessment. And I've done it. I did it a week ago, and she's just asked me again. So that's a sign. The staff might notice. So then we follow up with cognitive screening. Okay, thanks, Mary. We'll have a look at what this cognitive screening is. Okay. So, well, this is just a few other ways of assessing risk factors. So we've asked the questions about memory and thinking, or the staff have raised concerns, or the family have raised concerns, or we've had a look at, you know, diabetes or chronic illness or stroke or epilepsy or head injury, or in fact stolen generation being a risk factor in itself, or other psychosocial factors. And we've decided we're going to use a cognitive screening tool. And there's 3 that are mentioned down there at the bottom of that slide. And they are clock drawing test, the kicker, which is a specific tool for Aboriginal and Torres Strait Islander people, or the mini mental state examination. And for those of you who work with desktop software in Australia, most of that software does have the MMSE on it. And that takes about 10 minutes to administer and includes some questions about the date and can you spell the word world backwards, and can you copy a diagram and so on. And I'm mentioning that first because it's very common, but it's actually not particularly sensitive to dementia. And it's not necessarily very appropriate for Aboriginal and Torres Strait Islander people for a range of reasons. So the kicker, which in fact Dina Letschat, who's introduced this, was very instrumental in getting the kicker up and running. She did the first groundwork on it in the Kimberley. And so that's a much more familiar sort of questions for Aboriginal and Torres Strait Islander people. And there's also a clock drawing. You can do a clock drawing by 3 simple steps. Draw a circle for the person. Give them that piece of paper and ask them to put in the numbers for a clock. And then ask them to draw the hands at 10 past 11. And if you think about it, 10 past 11 means the shorthand's just a bit after 11 and the longhand is at 2. At 2. You really have to think hard to get that right. And it's very difficult for people who've got cognitive impairment. Okay, so we'll look at the next slide. Thanks. So there we are. That's some sort of summarize it. There are concerns. There's the cognitive screening. We've talked about that. And then there's a full clinical assessment. Okay, so let's have a look and see what is involved with that. Okay, so if Auntie Molly was sitting there with Frank, I might ask Frank, perhaps I might ask him in front of Auntie Molly or maybe separately, depending on how that relationship's working out. I might ask him, is this memory problem, is this something that's come on just recently in the last week or 2? Because I can tell you now, if that is the case, it is not dementia. It is much more likely to be an infection, such as a urinary tract infection or some other illness. For dementia, the memory problems and the changes in behaviour are much more chronic and they sort of creep up on people over time. And another thing is that it needs to be a change from a previous level. So if the person's always had a terrible memory, it's no good starting to think about them having dementia when they're no worse than they ever were. That's the way they are. And there's also functional decline. So you want to know, particularly activities of daily living like cooking. Cooking is very sensitive to dementia. You have to line everything up, get it all cooked at the same time and served on a plate, all hot, not with some of it cooked and some of it still stone cold. And you don't want to see your patient up in Coles shopping for food halfway through dinner because they've forgotten some of the ingredients. And I have had that happen. We've talked about the cognitive assessment. We've talked about a little bit about delirium, which is the infection, or perhaps if the person's just come out of hospital, often they've got a low sodium or something like that. So that can cause delirium and difficulty with thinking. The person might be depressed, and in fact, Auntie Molly might be depressed. And that can look very like dementia. The person doesn't want to do anything, they sit around, they're not interested in things the way they were before. And that could be depression, but it could also be dementia. And I've been told by a psychiatrist that with depression, people feel bad. They feel bad inside. Whereas if it's dementia that's making them sit around and kind of not be interested in things, they're not feeling bad. They'll say, oh, I feel fine. But they've just stopped. They've just withdrawn because they're not thinking as much anymore. We need to review medications. Now, there's a couple of components to that. One is a lot of people, as they get older, are on an awful lot of medications. And if you've got cognitive impairment, you are not going to remember all those medications. And I have difficulty remembering to take my fish oil capsules. and that's one medication. But if you're on 15 different ones, forget it. So it's a very good idea for those of us who are able to review medications to try and reduce the medications as much as possible, or perhaps consider a Webster pack from the chemist. The other thing is, what medications are they? Are they ones that are likely to affect someone's thinking? And that might be, a sleeping tablet of some sort. It might be some other sort of anti-anxiety tablet. Often we think of Valium or something like that, but even Normicin or some of those very common sleeping tablets, Tamaze, might be enough to make people not think clearly. Even if they've been on them for years, as they get older, the brain becomes more sensitive to those things. And the other big group are anticholinergic medications. And the GPs in the audience will know about the dry mouth that you get from an anticholinergic medication. But we're not always aware that it also affects people's thinking and that they can't think as clearly when they're on an anticholinergic, particularly as they get older. And the common ones are the ones for urinary incontinence that people get put on as they get older. Very good for urinary incontinence, but are really, really bad for memory and thinking. So in order to make sure that the person doesn't have a delirium, we need to do some blood tests, a full blood examination, checking for low iron, electrolytes, urea, creatinine, looking at renal function. That's a common problem in Aboriginal people. Or if the electrolytes are abnormal, I mentioned the sodium. Liver function tests, calcium, if that's awry, that will also cause problems with thinking and memory. Thyroid, of course, a low thyroid, it's very difficult for people to think clearly, but hyperthyroidism can also interfere with thinking. And a low B12 and folate are also problematic for people. And I mentioned that if you're thinking that they might have some sort of infection and it's been a fairly recent change, you might be wanting to do a urine dipstick or an MSU and have a listen to their chest, especially if they're a smoker. Maybe they've got a chest infection. We do a CT of the brain. Some people do an MRI if you're in the middle of the big city. GPs can't order an MRI for this indication under Medicare. The brain CT is mainly to eliminate the possibility of a brain tumour or something like normal pressure, hydrocephalus or something else that's reversible that's causing this problem. Although the clever doctors, especially with an MRI, can start to pick which bits of the brain are affected and subcategorise a sort of dementia as well. But for general practice, I think you're doing a CT in order to make sure, or a subdural. Maybe they've fallen and hadn't thought twice about it, and they've actually got a chronic subdural, and that's affecting them. And some of that's reversible. And then we can consider referral for further assessment if it's not clear to us, or if there's ready availability of that. That might depend where you are. Okay, next one, Mary. Okay, so this is the last of my bit. So once you've identified cognitive impairment, and that may be an iterative process, getting people back and watching, maybe repeating your cognitive function test a few times and watching it going downhill. That's very important. Then you might think about incorporating that understanding when you do a care plan for the person. So the care plan will be affected, the way the person is able to look after themselves will be affected by their cognitive impairment. So the care plan may need to include a pharmacy review, for example. It may need to include a Webster pack. It may need to include regular reminders from the practice about attending to allied health, to coming back to see the doctor, in fact. because people forget. They might not be checking their blood sugar levels as often as they should, although you don't have to do that as much with type 2. And then there's also a whole range of things to optimise brain health, in particular diet and exercise interventions. And we've got some resources for that we'll be sending out. So I'll hand back to Mary. Thanks, Mary.
Thanks, Dimity. So just bringing this map up again, we've touched on the prevention, and as I said, there'll be a webinar about that sort of explores that better in the future. And Dimity's outlined the approach to detection and diagnosis, and we're now going to talk a bit about living with cognitive impairment and particularly dementia. So, as defined by the Lancet systematic review, they articulated the sort of goals of care should aim to support quality of life, to maintain function, and to maximise comfort. And, you know, they're sort of pretty universal aims. They're not particular to Aboriginal and Torres Strait Islander people. It's also the key part around support and care of carers. And we'll talk a little bit about that further on. And that good dementia care is supported by continuity of care and by multidisciplinary case management approach, which I think for the clinicians here, you know, would easily recognise that they're the continuity of care and case management approach is sort of sound principles for, you know, any complex and chronic conditions. But some other sort of really important principles are to remember general health care as well as dementia-specific care. So, you know, general health care including oral, dental care, immunisation, sort of general things that are part of primary health care, you know, as well as the you know, prescribing dementia medications or other aspects of dementia-specific care, that it's person and in all the Delphi process and the feedback that we've got from community, strong messages for Aboriginal and Torres Strait Islander people around family-centred care. So not just person, individual-centred care, but really family-centred care. And of course, that, you know, there's access to appropriate services, and thinking about, you know, that's access about availability, and, you know, there's lots of variation in across the geographic settings for people, and then the other issues around access and equity that are, you know, actually being able to get there and to afford them and to have services that are that feel safe and appropriate, which is actually that last point around, you know, being culturally appropriate and trauma informed. And one of the really strong principles around regular review, you know, as disease progresses and needs change a lot, and just, you know, scheduling regular review is key. So within the guide, this is one of the ways that we've sort of depicted that. It's a summary, you know, obviously. We've been, I noticed that we haven't, but meant to, that traditional healers in many communities may be an important part of their healthcare team. And I think, you know, really this is this sort of outlines, just gives a framework for the sort of domains of health needs that we need to think about. I'll talk a little bit more about my aged care in a moment. Important principle, so around personal preferences is that whatever level of cognition a person has, their preferences should always be central. So introducing conversations about personal preferences and planning early and revisiting them regularly is key. That may be then formalised as advanced care planning or not. In my experience, often not, even when there are lots of conversations that are about personal preferences and planning and anticipating how things might change. Decision-making with a lot of Aboriginal and Torres Strait Islander people, and really holding in mind too that there is so much diversity that generalisations, one has to be careful, but there is, for many Aboriginal and Torres Strait Islander people, decision-making may be deeply shared and a collective experience, or it might not be. It might be very private and individual, so it needs to be checked. But I've had experiences working in desert communities where one case meeting or a family meeting that I had with a woman who had advanced renal failure, I recall, who was really facing either renal replacement therapy or else she was approaching the end of her life. And it was, I witnessed really closely what a shared decision that was. It wasn't just people supporting her to make the decision. She shared that decision and the responsibility for that decision with a much broader group of people, and that's common. So it's really, really need to check how people are connected and who they want involved in decisions. And on the other hand, you can't actually assume that it's going to be shared with family members. So it's important to identify who's authorised to make decisions, and, again, consider formalising that in appointing or supporting people, helping people to appoint powers of attorney and for health and for administrative reasons. The importance of country and the place of care and end of life needs to be really carefully and sensitively considered, but that's often really, really key for people. And of course, quality of life may mean different things, does mean different things to different people. And there is a Good Spirit, Good Life tool that's a quality of life assessment tool that has been developed with Aboriginal people and sort of validated in Aboriginal communities, and there's a link to that in the resources. So, just around decision making, I mean, this is where a geriatrician can be really helpful in assisting with assessing capacity, and that can be really useful in knowing how to how to use the support or shared decision making. Okay, so about carers and family, there's a few sort of particular things that are common in Aboriginal Torres Strait Islander settings, where carers may often be older people with their own complex health needs, or they may be much younger people, family members with their own young families and have complex health and social issues. They may have culturally based or spiritual beliefs about changes in thinking or memory, which can sometimes be reasons for not accessing healthcare. And that needs to sort of be explored, like respected and explored, but really important how the health messages are given and the explanations of dementia are given, that is, cognizant and respectful of people's ways of thinking and understanding about health. And of course, carers maybe family members and have the same sort of population risk profile for cognitive impairment. There's, evidence across, like, in the international literature about the negative impact on carers, that carers may have poorer health and experience social isolation, and that's true for Aboriginal and Torres Strait Islander communities too. And another factor that's common is that a person with dementia may be a carer themselves, and that's just enormously complex. There's many grandparents who have grandchildren in their care. So just really important to know what's available in your area to support carers and families. And one of the webinars later in the series will be focusing on this. Okay, so end of life and advanced care planning. I guess just the things to say about this are the importance of local cultural protocols and practices in relation to end of life. Very hard to generalise. It's just so important to check in and know what the local knowledge is. Important to engage specialists in a timely manner. People with dementia, it may be really useful to involve palliative care teams or specialists when they're available, and that may be for support of the primary care team or for the family, and it's available by telehealth. And one of the great gifts of COVID is the way telehealth has become much more standardised and much more accessible. Still plenty of work to do in terms of equity of access to that, but it's definitely worth considering the use of specialist services. These are some resources. The Dying to Talk resource is a really useful tool to sort of guide and support conversations with people about end-of-life preparation. And, just an abiding principle is to involve Aboriginal and Torres Strait Islander people whenever possible. Couple of sort of logistical things, but really important to know. Aboriginal and Torres Strait Islander people are eligible for enrolment in my aged care at 50 years of age. So obviously, as a gateway to funded services, it's really important to know that. Secondly, a little bit about the Close the Gap PBS co-payment for Aboriginal and Torres Strait Islander people. So there'll be the GPs and perhaps some of the nurses, people who are working in Aboriginal health will be completely familiar with this. There may be people who aren't. So that's it's a subsidy scheme that was introduced in 2010 to support access to medications, and basically it allows access to PBS medications for Aboriginal and Torres Strait Islander people who are on a healthcare card, access medications at no cost, and for people who aren't, they're at the subsidised cost that it would be with a healthcare card, so $6.40 or so per medication. Okay, it requires enrolment. So the people who are eligible are anyone who self-identifies. So people don't need to provide proof other than self-identifying as Aboriginal and Torres Strait Islander. That the clinician believes that enrolment in this will support adherence to the medications, and that they're enrolled in Medicare. So it's pretty broad, and it's a once-off registration. Clinicians, so GPs or their nominated person, can register a person or check registration status on HPOS, and any PBS prescriber or Aboriginal health worker or practitioner can register a patient. It's a really practical way. It was just a fantastic initiative. I remember I was the medical director at the Victorian Aboriginal Health Service when this came in, and it was really transformative. So it's important to know about this. Up until July this year, so for 11 years, the clinicians had to be registered themselves to be able to prescribe like this. That's no longer the case. It's only about the patient now. Although a change from the 1st of July also includes that prescriptions don't need to be annotated. It's still advisable to, because there are some glitches in the system. So that means that any prescription for an Aboriginal Torres Strait Islander person, if that person is registered by HPOS with Services Australia, and the clinician writes CTG on the script, or it's in the software system that happens, that person will get the medications at the subsidised rate. So there's also a link in the resources for people who want to, just check out the details. And actually, that's where we are finishing. And here are some of the resources that are available. So the CTG co-payment information, the full guide and poster and a summary of the guide are available there. And the other tools that we referred to through the talk.